All the aspirants, we have Dr. Neeraj Kumar here. He is Associate Professor at AIMS Patna. Thank you, sir.
Thank you, Fatima, for your introduction. We have already started our course. So, just two or three things prior to start my course or my topic is that I have put all this because this is a EDIC part one crash course. So, I have made few questions, type K question and type A questions. For type K questions, you have true and false statement for which you can write the answers in the chat box only, and that for type A questions only one answer is correct, so you can write that answer in the chat box only. So I will be reading the questions, and then after that we will have a discussion one by one that why these options is correct. So, but before that, I should just request all the participants to keep their mic in mute mode so that no disturbance in the class would be there. Okay. And if any query, if any issues related to any of the discussion, you can write in the chat box also, or at the end of the class, I will share my email for clearing all your doubts. Okay. So, first of all, I will start with type K questions, in which the first question is that most of the patient, because we have discussing here superior vena cava syndrome. So most patient with SBC syndrome, you have to identify the true and false statement, right? So there are various fact-based questions which I have taken from the latest edition of Irwin and Rippe. Few of the questions has been taken from the journals, and few of the questions has been taken from the other textbooks also of the critical care medicine. Now, this for this question, the first option is they are having a bronchogenic carcinoma. So they have an association with bronchogenic carcinoma first. Second option is the most common histology that you will find in SBC syndrome is confined to small cell, or the most common histology is confined to squamous cell. The D option is benign causes of SBC syndrome exist in 60 to 70% of the cases, and it includes the thrombosis because of the indwelling catheter. The last option is patient with benign causes can develop extensive collateral flow, which that develops and it minimizes the symptoms. Okay, so any of you who want to attempt this question, you can write on the chat box. Good, very nice. So two of you have opted for this options, like you feel that first two options are true, and then next two options are false, and then last option is true. Okay. So just see the answer. So the first two statements are true. The other two statements are false, and the last statement is also true. Okay. Good. Now you see that why it is so. So if we'll talk about this superior vena cava syndrome, so if you'll see that maximum of this patient, they are vast majority of the patient, they have bronchogenic carcinoma. They have a history of bronchogenic carcinoma, and then out of this, most common is small cell histology. Okay, and non-Hodgkin's lymphoma, thymic neoplasm, and there are other neoplasm that make the metastasis and the remainder up to the malignant causes. Okay, and the benign causes of these SBC syndrome exist in up to 40% of the cases only, which includes thrombosis due to your indwelling catheters. Okay. And the second important thing is most of the patient, they have a presentation. They in this patient, the benign causes is because of the extensive collateral flow, and they often develops that minimizes the symptoms, so that they can minimize the symptoms up to a month or year. So now coming to the next part is diagnosis. So if you see the small cell constitutes around 34% of the patients, and then coming to the second part is your squamous cell. So first is your small cell and followed by squamous cell. Okay, now coming to the continuing to the same question. So the what is the chemotherapy? Chemotherapy is the treatment of choice for SBC syndrome, but you have to identify the true and false statement. So this chemotherapy is the treatment of choice for small cell lung carcinoma, for non-Hodgkin's lymphoma, for germ cell tumors, and the D option is 80% of these patients have complete or partial response to their symptoms to chemotherapy, and E option is radiation therapy prior to biopsy has been associated with a significant reduction in the rates of histological diagnosis. That's why it should be avoided. Okay. So many of you have marked this question. The first statement is false, second statement is true, then false, and then true. Okay. Any other participant who want to attempt this question? So you have to identify the true and false statement regarding chemotherapy. Okay. Okay, let's see the answers. So the first statement, like here, for this is the main indications for using chemotherapy, right? So all these options, like first three statements are correct for using the choice for chemotherapy, and 80%, yes, definitely more than 80, approximately 80% of these patients have complete or partial response to the chemotherapy, and radiation therapy prior to biopsy has been associated with significant reduction. Now you see the statement that has been taken from the Irwin and Rippe book, where the chemotherapy is the treatment of choice for SBC syndrome due to small cell lung carcinoma, non-Hodgkin's lymphoma, and germ cell tumor. So all these tumors are indications, and 80% of these patients have either complete or partial response to symptoms to chemotherapy alone. So if you'll get any options that chemotherapy is the choice of treatment, chemotherapy is the choice of treatment in 80% of the patients. However, if you want to do a radiation therapy prior to biopsy, it has been associated with significant reduction in the rate of getting that positive histological diagnosis, and it should be avoided. Okay, so these are the four important statements or five important statements. Now coming to the next question, that mark the true and false statement regarding. So many of the malignancies, like malignancies most common associated with pericardial effusions are lung, breast, lymphoma, and leukemia. And common symptoms of pericardial effusion include cough, orthopnea, dyspnea, and chest pain. Plain films may demonstrate cardiac enlargement among more than 50% of the cases. Echocardiography is the most useful means of rapidly detecting hemodynamically significant pericardial effusion, and pericardial biopsy is occasionally required to establish a diagnosis for difficult case. So I will ask that just carefully see the options, because the options may be twisted at all, and there may be some of the changes or some of the modification in the language as well. Okay. Anyone more who wants to attempt this question? So you have to write true and false statement. So you write true or false, either all true or all false. You can write like that, or true, false, false statement like that. Okay, good. So here, I think if you'll see the choices, choices is very odd, but just a slight modifications. So the first options, these malignancies, true for pericardial effusions. These are the most common system where these malignancies are associated, and the second option is not true. I will show why. And the next other options, these are true statements. All these are true statements. Okay, so you just see why. So here, why it is so? Because if you'll see the literature, the malignancies are often associated with pericardial effusions related to the lung, breast, lymphoma, and leukemia. And most common symptoms for pericardial effusion is including your dyspnea, and then coming to the second part is cough, and then orthopnea, and then chest pain. I'll just request our participant to just mute your mic. And the second part is the related to the X-ray film. So X-ray film demonstrate a cardiac enlargement in about 50% of the patients. And last, echocardiography is the most useful means of rapidly detecting hemodynamically significant effusion. Okay. And here the last choice is for pericardial biopsy is occasionally required to establish a diagnosis for difficult case. Okay, I just twisted that option. That pericardial biopsy is occasionally required to establish a diagnosis. You may get a question that pericardial biopsy is frequently required to establish a diagnosis for difficult case. So you just read those options very carefully. Okay. Now coming to the next question. So this is about true and false statement about epidural cord compressions by malignancy. Okay, so because the metastasis of primary tumor, involvement of the vertebral column, paravertebral space, and epidural space occurs because of the epidural cord compression. And vertebral body is the most common source of compressive lesions, predominantly in the lumbar region, 60%, followed by thoracic 25, and cervical 15%. Cardinal signs of malignant cord compression is pain, and it is present among 95% of the patients at diagnosis. Median time, if you look for the median time from pain onset to a diagnosis of cord compression, it usually takes 6 months. And therapeutic options include corticosteroid surgery and radiation. Okay. Now, how many of you mark it true? Let's see. Anyone more wants to attempt this question? So again, this is a bit tricky question. Many of the statement directly taken from the test book, and few of them is modified. Okay, good. So many of you guys are attempting this question, so it's nice. So if you'll see that first option is metastasis primary tumor involvement is related to the vertebral column. So the epidural cord compression may appear at vertebral columns level, at paravertebral space, or at epidural space. The second option is not true. Vertebral body is the most common source of compressive lesion. The partial statement is right, but predominantly not in the lumbar, not in the thoracic, not in the cervical. The percentage is bit different. And third sign is cardinal sign of pain is perfectly right. And fourth option is not right. Median time of pain onset to diagnosis cord compression is not 6 months. And last option, the therapeutic option include all three statements. Okay, just see the statements. How? So these epidural compressions malignancy occurs as a result. Why these appears? These occurs because of the metastasis or because of the primary tumor involvement to the vertebral column, paravertebral space, or epidural space first. And these vertebral bodies, the most common compressive lesions, predominantly in the thoracic lesion, it is 60%, followed by lumbar 25 and cervical 15%. And these tumor invasion through the intervertebral foramen. Now, the next statement is the cardinal sign of malignant cord compression is pain in 95% of the patient, and median time for the onset of diagnosis to cord compression is approximately 2 months. Okay, and the next option, therapeutic options for these corticosteroids include your radiation surgery and corticosteroids. And for emergent situation, corticosteroids is usually given while awaiting MRA to decrease the peritumoral edema and to prevent edema formation, which usually happens at the time of radiation. Okay. So now coming to the next question. So mark the true and false statement for non-malignant causes of hypercalcemia. So what are which of the following are non-malignant causes of hypercalcemia? So you have to mark true and false statement. Okay. Then I will discuss one chart in which the causes is written there. So it is HCM, non-malignant causes of hypercalcemia of, we used to read hypercalcemia of malignancy, but where the malignancy is the most common cause because of PTHRP hormones. But here the non-malignant causes of hypercalcemia is there. So any of you who wants to attempt this question, writing true and false, whether TPN can cause hypercalcemia. So here I think the option is bit twisted because here the mark true and false statements for non-malignant causes of hypercalcemia, except it is written. So I think question is not partially correct, but you can write that which of the following options can cause hypercalcemia and which is not. So you can write that don't read except in this question. So I think that option will be only one because here there are 5 different forms is there, but I will go straight away. This question is a bit wrongly written here. So if you'll see the true and false statement. So first statement is true, TPN is the cause. Second statement is not true. So potassium sparing diuretics is not true. And I think then hypervitaminosis, again, it's true statement. Sumatriptan cannot cause that hypercalcemia, and then lithium toxicity can cause that hypertoxicemia. Okay. I think Altaf, can you mute your mic, please? Altaf, mute your mic. Thank you. Thank you so much. So this is all about your hypercalcemia of malignancy. Now, if you see that what could be the probable options. So the diagnosis of hypercalcemia is documented. So here hypercalcemia is always documented by the presence of elevated calcium. Till now, we all know that. And here, if the patient is hypoalbuminic, if the patient is having a decreased albumin level, so you have to measure the serum calcium level, and that is always lower than actual calcium concentration, right? But here we ask the causes for the cancer that has to be evaluated, like for non-malignant causes of hypercalcemia, which include hyperparathyroidism, intravenous fluids, total parenteral nutrition, milk alkali syndrome, thiazide diuretics, hypervitaminosis A and D, and then lithium toxicity. Okay, so these are the few of the important aspects when you are evaluating the causes for the hypercalcemia. We used to send all those investigation related to PTH, PTHRP, blood urea nitrogen, creatinine, phosphate, and magnesium. But meanwhile, you have to think for the various causes, non-malignant causes, which can lead rise to your hypercalcemia as well. Now, coming to the important aspects about red blood cell exchange. So there is a term that is known as red blood cell exchange. So you have to write what are the true statements and false statement for this RCE. So red blood or RBCE, red blood cell exchange. So it is useful for the patient with severe clinical manifestation of falciparum malaria or babesiosis. And second, it is the automated RC is also known as erythrocytopheresis. This modality is not able to maintain euvolemia and hyperviscosity complications. The automated RC may be considered as an alternative to small volume phlebotomy for selected patients with controlled erythrocytosis, and the use of RC is for selected patients with sickle cell disease who are experiencing, means who have a symptoms like acute chest syndrome, priapism, or splenic sequestration. So I think our answer is already shown on that table. So the first two statement, like this statement and this statement, is true, and but the next these two statements are not true. The last statement is also true. So we will focus on the second C options and D option, where it is not true. Okay, because this is an alternative to large volume phlebotomy. This is not an alternative to small volume phlebotomy, and this modality not able to maintains euvolemia is not. This modality maintains euvolemia and hyperviscosity complications. Now you see why. So we know that these red blood cell exchange is basically a treatment strategy for few of the selected patients who are having a sickle cell disease but experiencing some of the complications, right? Because of the splenic or hepatic sequestration or multi-organ failure. And this is also known as erythrocytopheresis. Now, why it is known as erythrocytopheresis? Because it rapidly reduces the level of hemoglobin S positive cells. And their target or their goal is to reduce these levels to at least 30%, right? And the second important problem is this modality always maintains the U volume. It doesn't causes volume depletion. It doesn't cause hypotension, and it also minimizes the viscosity or viscosity drag. So it covers or it lessens the hyper viscosity related complications as well. Now coming to the next option. So if we'll see that this RC may be useful for the patient with severe clinical manifestation of falciparum, that is complicated malaria, or babesiosis. So babesiosis is one of the important evidence-based established treatment for the RC is the established treatment for babesiosis. And why they told that, and they told in a recent review in 19 patients that after receiving these RBC exchange transfusion for babesiosis, they showed that the procedure could reduce the parasitic load by 75%. So at least 75 to 80% of the load is going to get reduced. Now, these automated red cell exchange may be considered as an alternative to large volume phlebotomy for a selected group of patients where the erythrocytosis is uncontrolled and patient is having a polycythemia vera with some acute thromboembolic features like severe microvascular complications. So you must keep it in your mind that what will be the cutoff point at which the large volume phlebotomy is not required if you are targeting automated cell exchange therapies. So these are few of the indications. I hope this is correct for you all. Now coming to the important, interesting questions about cholesterol embolism. So what is cholesterol embolism? So it is a clinical picture that is very similar to that of systemic vasculitis. It is acute onset in nature of peripheral skin lesions. So peripheral skin lesions going to get involved. So bowel ischemia, patient will have acute confusional state, and retinal embolization may also take place. The treatment of cholesterol emboli includes the use of heparin and warfarin, and cholesterol crystals display a dual bisrefringence when viewed with a polarized light microscope. So I think again the options is written here, but I will go straight away that if you'll see the clinical picture, yes, it is very likely clearly visible with systemic vasculitis, many of the patients, and these patients have never a acute onset. It takes long times to develop peripheral skin lesions, and many of the patients always present with bowel ischemia, some acute neurological deficit, as well as the change in the vision, like retinal embolization leading to blurring of the vision as well. And never, that cholesterol emboli is never going to get treated by using heparin and warfarin. And even the cholesterol crystal display, not it display a dual, it shows a dual bis references, but not dual bis bireferences when used with a polarized light microscope. Now you see why. Now, what is this cholesterol crystal embolization? It is basically gradual in onset skin lesions. Typically, the patient will present a blue toe or livedo reticularis with a worsening of renal function. And you will see that this patient will have a gradually increase in serum creatinine as well as uremia, and the patient will have some these bowel ischemia as well. And this syndrome usually occurs because of the eroded atherosclerotic plaques. That's why many of the patients who are having impaired renal functions after angiography, they may help to distinguish mainly contrast-induced nephropathy from renal failure due to atheromatous microemboli. So it is very important differential diagnosis for contrast-induced nephropathy, where you can have an angiography for distinguishing this cholesterol embolism from your contrast-induced nephropathy. Now, if you see the next important point, that when you look these patients with a special histological preparation, these crystals display a bisrefringence when viewed with a polarized light microscope, right? And the use of heparin as well as warfarin is always controversial. That's why the treatment for the choice for controlling, because these patients have a very much pain. That's why the pain has to be controlled using various topical glyceryl trinitrate, because it will increase the local blood flow. You can do a sympathetic blockade. You can use calcium channel blockers to reduce that persistent vasospasm in these groups of patients. Pentoxifylline has been tried in few of the patients for improving the rheostatic properties of the red blood cells. However, the new vasophosphodiesterase 3 inhibitors like ilioprost or PD inhibitors have been also tried. So there are lots of treatment for this. But what I want to highlight here, if you get a question on cholesterol emboli, just keep it in your mind that heparin and warfarin role is not there. Rest other roles you can very easily, like corticosteroid, like your low molecular, like your that your even low molecular dextrans, these are not useful at all. These are ineffective treatment. So I thought that I should add these questions for you all. Okay, now coming to the one few words about cold agglutinin disease. So CAD. So mark the true and false statement about cold agglutinin disease. So again, you read these options very carefully. I think here answer is not visible. So first option is it is related to immunoglobulin M antibodies, and it targets the white blood cells surface antigen, typically with specificity to either eye or big eye or small eye. And IgM antibodies, they optimally bind to these white blood cells at cold temperature, typically at less than 32 degrees Celsius, but more strongly they bind at 4 degrees Celsius. And when you'll do Coombs test, the C3 complement is usually negative, whereas IgG is positive. And the second part is examination of peripheral blood smear will show agglutination of erythrocytes, and corticosteroids and splenectomy are the most effective treatment for your cold agglutinin disease as compared to WAHA, that is warm autoimmune hemolytic anemia. So how many of you wants to mark this true statement? First, before these two options are, I think already we have shown the answers, but here anyone who can mark about this cold agglutinin disease? Okay. Okay, many of you feels that for the first option is false, and rest other three options are true. Okay, I think here the if you'll see the carefully, the answer is there in this in the options only. Okay. So we'll read about, again, it's a very important topic. We'll read about cold agglutinin disease. So what is this cold agglutinin disease? So if you'll see that all three options are wrong. Why? Because if you'll see carefully, I have just modified this one and I have modified this one also. So if you'll closely look, so it should be red. Okay, not white blood cells. So here it should be red, and rest option here it should be IgG antibodies, or if you'll carefully look here, I have written the IgG is positive. Okay, let's see why. So now for agglutinin disease or agglutinin disease or IgM antibodies, here what happens? These IgM antibodies targets red cell surface antigens, and typically they have a very high specificity to either big I or small I. And these IgM antibodies, these optimally binds to a cold temperature which starts with 32 degrees Celsius, and extreme cold is 4 degrees Celsius. So you have to see these options very carefully. So it is not WBC, it is RBC. And then the second option is these cold agglutinin titer. If you'll do a Coombs test, most of the times the IgG is always negative. IgG is always negative. Okay. IgG is always negative because here IgM positivity is there. So your IgM is always negative, and underlying IgM auto antibody, because it reflects the underlying IgM auto antibody, which is more efficiently fixing the complement as well. So C3 is positive and your IgG is negative. And if you see for the treatment, so there is mild CAD where mainstream treatment is avoid cold temperature less than 32 or up to 4 degrees Celsius. You can definitely add corticosteroids or you can do a splenectomy if because they are least effective in CAD as compared to YHA. Okay. That's why if you'll see that corticosteroids are most effective treatment in the CAD, no, it is not most effective. It is the least effective treatment, and that this option on peripheral examination, blood. Okay, on peripheral examination, I'll show you. On peripheral examination, if you'll see that examination of peripheral blood wear will show agglutination of erythrocytes. Okay. So if you have must closely seen this option, so here erythrocytes and here leukocytes is written there. So either of these option will be right or this option will be right. Okay. So till now, I'm very much sure that you all guys have must understood about that concept of cold agglutinin disease, but you have to read it later also. Now coming to the next point. Okay, next point also. Next point is true and false statement regarding paroxysmal cold hemoglobinuria. So it is common form of acquired form of hemolytic anemia. So it is not true. So the pathogenic antibody is IgG. Yes, the pathogenic antibody is IgG. And these IgG in this PCH bind to RBC and fixes the complement only at a temperature range of 4 degrees Celsius. Though again, this is not true. And the third option is not true. Fourth option, hemolysis usually not happens after rewarming. Again, this is a very, very strong statement. And this is not right statement, but I will read it later because it is taken directly from the textbook. And diagnosis is always made by the detection of Donat-Landsteiner antibody. So you'd see that it is not written always made by detection of Donat-Landsteiner antibody, but diagnosis can be made by seeing or detecting the Donat-Landsteiner antibody. Now you see why. So here the PCH is a very rare acquired form of hemolytic anemia, and pathogenic antibodies IgG. The similar to IgM antibodies in CAD, the IgG antibodies bind to RBC and it fixes the complement only at cold temperature ranging from 32 degrees Celsius. But unlike CAD, the hemolysis in PCH happens after rewarming. So there is very, very close association between this PCH and your CAD. So if you try to remember PCH, so it is PCH and then G. Okay. So G is for IgG antibody, and for CAD it is M. So CAD it is M. So you remember PCHG, so you can remember your paroxysmal cold chain hemoglobinuria. It is for IgG antibodies, and here the IgG binds to RBC at less than 32 degrees Celsius, but a strong binding happens in CAD at 4 degrees Celsius, but it is for IgM antibodies. Okay. The second point is, many of the times hemolysis always occurs when you will be rewarming your patients, but these hemolysis will not occur if you rewarm your patient in CAD. The second important aspect is the diagnosis is made by the detection of Donat Landsteiner antibodies. And if you'll do a Coombs test, so it is G. So your IgG, typically the IgG will be negative and complement will be positive. So complement will be positive in both the cases, but your IgG and IgM will be negative for CAD diagnosis. Okay. So you have to carefully look up all these options. Now coming to the few statements about your true and false statement regarding acute lymphoblastic leukemia. So I want to test your knowledge related to ALL. So ALL, many of the patients, 9 to 27% of the ICU admissions for hematological malignancy. So it constitutes less than 30% of the ICU admission. 10-year survival among all adults with ALL is more than 30%. 30%. If we'll see favorable disease outcome, the age is one of the factor, like 1 to 15 years, and translocation 9 to 22, and BCR-ABL translocation like Philadelphia chromosome translocation, it represents 15 to 20% of the adult cases of ALL. And last option, that minimal residual disease, if it is negative, it possesses a favorable outcome in ALL. So how many of you think that which statement is true and which statement is false? So I think 3 or 4 important facts are there for acute lymphoblastic leukemia. If you know it right, it's wise. If you doesn't know, you have to read all those textbooks. Anyone who wants to mark? Okay, let's go. Let's see a few statements because they go in ALL. I think many of the times, good in ALL, many of the times what happens now, they used to ask the question related to that favorable outcome and on non-favorable outcome. Okay, so you have to remember that table, favorable outcome and non-favorable outcome, out of which I have added only one statement. So if you'll see that options like first statement is true. It's a fact that less than 30% of the ICU admissions, these ALL patients are there, is there. And second option is not true because it is not 10 years of survival. It is not 10-year survival. And third statement is also true, fourth is also true, and fifth is also true. So this BCR-ABL translocation happens in only 20% of the patient. 80% of the patient doesn't show that BCR-ABL 9 to 22 translocation. And these minimum residual disease, if it is negative, it has a good outcome, favorable outcome. And favorable outcome is also 1 to 15 years of age. And if the age is less than 1 year, so the outcome is not favorable. Now you see the statements. So why? These ALL patients comprise 9 to 27% of the ICU admissions of all hematological malignancy, and this is 10 years survivals among the patient adult is less than 30%. Okay, it is more than 30% is written there, so it is not true. And coming to the next statement. So favorable disease outcome, here the favorable disease outcome is age 1 to 15 years. If your patient have a WBC count of less than 30,000, if you for B cell, or less than 50 to 1 lakh per microliter for T cell ALL, and for B cell ALL, it is cutoff is less than 30,000, and for T cell ALL, the cutoff is 50 to 10,000. Okay, 50 to 1 lakh. And rapid achievement of complete remission is another favorable outcome, and minimal residual disease negativity is favorable outcome. Age more than 35 years is unfavorable outcome, and patient with T92 BCR-ABL translocation, it represent only 15 to 20% of the all cases of ALL. Okay. There is again the long-term survival with the chemotherapy alone, and with long-term survival of after allogenic hematopoietic stem cell transplantation or transplantation is ranging from 20 to 45%. So it is another fact. Okay. Now coming to the one liner only. So this is type A questions. So I will discuss 10 type A questions right now. So you just all be ready for marking those options right. So first option is, which of the following statement regarding carboplatin, cisplatin, and oxyplatin are false? So they, because this question is taken with a anaphylaxis or a life-threatening anaphylaxis related to carboplatin, cisplatin, and oxyplatin. So these are both, all these types are type 1 and type 2 anaphylaxis reactions. The incidence increases after starting 6 to 7 cycles of chemotherapy. Anaphylaxis typically occurs when the drug is again rechallenged and considered pre-medication with corticosteroid is always required. You may get diffuse erythroderma, chest tightness, bronchospasm, and these are some of the classical symptoms. So you have to identify the false statement. Okay. So anaphylaxis typically occurs when drug is challenged, rechallenged. Okay. Anyone more who want to mark this? Okay. Incidence increases after 6 to 7 cycles of chemotherapy. Okay, anyone more? I think 20, 21 people are there, but only 3 or 4 guys are attempting. I think you all guys can attempt. Mark it wrong or right. It doesn't make any sense. At least you will remember all those options, or you can remember the topic and you can later on read. Okay. Okay. So you see that why this option is not right. So all these statements are true. First statement true. Second is also true. Third is also true. And this is also true. This statement doesn't. This is not true for this carboplatins group or cisplatin groups or oxyplatin groups. Okay. Now see why. So these are the agent associated with probability of severe life-threatening reactions. Okay. So these platinum agents like platin, cisplatin, and oxyplatin, they always show type 1 and type 2 reaction. It is right. And it is Ig mediated hypersensitivity. And this is always a classical hypersensitivity. These patients have a diffuse chest erythroderma and bronchospasm, facial swelling. And these the incidence always increases with repeated exposure, not with the first exposure. If you are repeatedly using oxyplatin and cisplatin, at least 6 to 7 cycles. So the cutoff is your 6 to 7 cycles is the cutoff, not first, not second, not third, not fifth. At least 6 cycles has to be given to check for any life-threatening reactions. And they typically these drugs, these life-threatening reactions always happens when the drug is rechallenged. Desensitization can be also performed. So the last option means the D option means this pre-medication is not required with corticosteroids prior to starting these platin groups of drug. Similarly, again, another question based on that only regarding alemtuzumab, anti-CD3 or OKT3 antibody. The first statement you have to write whether it is a non-antigen specific toxicity. First, symptoms usually occur within a minute to hour after infusion. Treatment may consist of corticosteroid or cytokine and antagonist. Successful rechallenge can be performed with pre-medications, and tachypnea, tachycardia, headache, mental status, tremor, or seizures may happen as a usual presentation. So you have to mark only false statement. It means rest all other statement are true regarding alemtuzumab or OKT3 antibody or anti-CT3 antibody. Okay. So you feel that tachypnea, tachycardia, headache, this is not right. Okay. But this option is not right. This so successful rechallenge cannot be performed with medication. This is not right at all. Rest other options. So it is always showing a non-antigenic specific antibodies. Now you see the answer. Why? Because this is not type 1, type 2 antigen Ig mediated response. This is cytokine release syndrome anaphylaxis. So you understand this is one of the important questions that may be asked in your exam related to anti-CD3 antibodies. So all or ATG antibodies, and here rituximab also, if they will ask about rituximab, so they show a cytokine release syndrome anaphylaxis, not type 1, not Ig mediated, not mast cell release. That's why it is a non-antigen specific toxicity. Many of the time the cytokines are going to get released in the form of interferon gamma, interferon B, IL-1 beta, IL-2, IL-6, IL-8, or TNF alpha, and these patients may present with tachypnea, tachycardia, headache, and the symptoms usually occurs within minutes to hours after the infusions, and the treatment may consist of corticosteroids and cytokine antagonists. So the option that what I have included here is the options for exclusion. So here the option will be the treatment successful re-challenge. Here the re-challenge term, re-challenge with medications are not required at all if you are using alemtuzumab. Rest all other options are true. So I think to your this immunoglobulins has been tested. Now you check for this question. So tumor lysis syndrome, again, very, very important question. Many of the times they used to ask about TLS in EDIC part 1. So here you have to identify the incorrect statement for TLS. Why I have posted most of the correct statement only to understand the concept for the important topic, that for these are the important questions that are important facts that they may going to get asked about TLS. So what you feel that which option, which of the following is incorrect? So all the following are correct, but which of the following is incorrect? So Cairo Bishop classification is most important diagnostic criteria for TLS, yes or no? Second, the risk for TLS always depends on the growth rate of the tumor and its sensitivity to the treatment. So again, the risk for TLS, and then tumor lysis syndrome always followed by hyperuricemia, then hyperkalemia, then hyperphosphatemia, hypocalcemia, and renal insufficiency. Many other times they used to ask about, they used to give hypercalcemia and the option is included. So hypocalcemia is there, hyperuricemia is there, hyperkalemia is there. Anyone who wants to mark? Okay. So you feel that risk of TLS depend on the growth rate of the tumor and sensitivity to treatment is not right. Okay. Any other? Okay. TLS is separated into types like laboratory TLS and clinical TLS. Okay. Anyone? Good. So I think you all guys have attempted. So now here you see that option. You all guys have not seen this option. The target urine output 1 ml per kg body weight per hour, intravenous hydration 4 to 5 ml per kg per body meter squared, like your body surface area per day should be given as the very high dose of hydration is required if the patient is having a TLS. So many of you might have not closely seen these options. Rest of the option is very, very true for this statement. Now you see why. So this tumor lysis is always followed by hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. This is the option they used to ask, but here this first option is true. The second is the risk for the TLS depend on the or growth rate of the tumor first, and then sensitivity to the treatment. Okay, so these are the two risk factors or risk indices for tumor lysis syndrome. And the second important is the Cairo-Bishop classification. Just wait. So Cairo-Bishop classification is most commonly been used for criteria for diagnosis of TLS. And many of the times we doesn't, they used to ask that these TLS is a laboratory tumor lysis syndrome and clinical TLS, that is clinical tumor lysis syndrome. If you'll see about the laboratory TLS syndrome, only two or more values of potassium, like potassium more than 6 milliequivalent, phosphorus more than 4.5 milligram per dl, uric acid more than 8, calcium less than 7, or 25% of the change in any of the variables. So to define a laboratory tumor lysis syndrome, it is defined by two or more of the potassium, two or more, either of potassium or phosphorus, anything. But to define a clinical TLS, it is defined by the presence of laboratory TLS, but plus at least kidney functions needs to be there. So how will you know that the patient will have a kidney function? If your baseline creatinine is raising more than 1.5 times to the upper limit normal, or the patient will have a second point cardiac arrhythmia, the third point seizure, or fourth point sudden. That is the last option for this TLS. And last, allopurinol in the dose of 200 to 600 milligram per meter square per day should be initiated. So the dose of allopurinol is this, and the intravenous hydration of 2 to 3 liter per meter body surface square is to be given with a target of 2 ml per kg body weight per hour. So you have to target the urine output more than 2 ml per kg per hour. So here intravenous hydration is 2 to 3, not high that what I have given you. Okay. So it is not high that what I have given. So just see this option. Okay. So you can't hear. Okay, just wait. Now I'm audible.
Yes.
Okay, thank you. So here the option is bit twisted. Now if you'll see that the hydration is 4 to 5 and close monitoring target is 2 ml and here 2 to 3. And here hypocalcemia is there. TLS is two types like laboratory TLS and clinical TLS. Okay. Now coming to the next question. So now it is this question is directly been taken from the Irvin Rippe book, where the which of the following mediators are associated with cytokine release syndrome. So you have to mark it true statement. Which of the following mediators are released in CRS? Okay, one liner. Okay, so two of you mark D. Good. So I think it's a straight question. But still, the cytokine release syndrome is a acute SIRS where fever and patient will have a chimeric CAR cell therapy is required for this, like your cytokine chimeric antigen receptor cell therapy is required, and these patients may need a haploidentical allogenic transplantation. And the first option is right because it is associated with your TNF alpha and interferon, like T helper 1 cytokines in addition to IL-4, IL-6, and IL-10. Okay, and these IL-5, IL-17, and 23, these are cytokine that is associated with allergic airway or arthritic inflammation, and prostaglandins are not considered as cytokines, and rantis and membrane chemotactin protein 1 and 4, these are also chemotactic cytokines and they are not associated with CRS. Okay, so this is a straight one. Now again, the important question is what is the most common apheresis procedure used for critical ill adults? Again, I think a very straight question. Maybe you all can. Yes, I think many of you have started marking correctly. Good. So this is your therapeutic plasma exchange. So this is the most common apheretic procedure that will used for critical ill patient. Now you see why. Of many of the choices, all are apheretic choices, right? And TPS except the last option where we have given some theory part. But this TP is the most commonly used for critical ill patients, like choice D is correct. Why? Because this strategy is first employed in 1952 in multiple myeloma patient to control the hyperviscosity. And by the year 1970, the TP has evolved a primary treatment modality for several immune mediated disease and large chain molecules. So I think again it's a one liner not related to apheresis, but a statement that small molecules with a small volume of distribution are more efficiently cleared by apheresis. So this statement is not true. Large molecule with small volume of distribution. So if a molecule is very large and having a very small volume of distribution, so these are always efficiently cleared by the process of apheresis. So again, this is important question one liner that you have to remember. Now coming to the next part, all of the following are DDs for microangiopathic hemolytic anemia, MAHA, except. So how many of you can mark? So I think answer is already written. So here you have to know the differential diagnosis for MAHA, where malignant hypertension, if a valve is malfunctioning, having a turbulent flow, it can give rise to a picture of MAHA. Okay. And severe vasculitis, scleroderma renal crisis, your antiphospholipid APLA can cause microangiopathic hemolytic anemia. If the patient will have a DIC, if the patient is having a HELP, if the patient is having a cyclosporine, taking ticlopidine, clopidogrel, or gemcitabine, or mitomycin C, all or anti-VEGF inhibitors, all these patients can have a your microangiopathic hemolytic anemia. Many of the times, if you are using left ventricular assist device, LVAD, or intra-aortic balloon pump device, the patient may be having a features for microangiopathic hemolytic anemia. So this is again a one-liner fact-based question that you have to remember. Now coming to the plasmic score. So plasmic score for prediction of ADMATS 13, which includes all except. So I have asked only one-liner about all of the following are component of plasmic score except, which is not a part of plasmic score. Okay. So if you look for this plasmic score, so how these for helping in diagnosis for severe ADMATs. Okay. Oh, okay, I think you have picked it right. Many of you have picked right. So this is no active cancer need to be there. Here, active cancer is not a part of plasmic score. So I think many of you guys have marked it right. So just see the plasmic score. They can ask that this plasmic score is for predicting the severity of ADMAT's deficiency, especially in TTP. And here the patient will have, these are the scoring points. So all have 1 point, and the patient will have, if the patient will have no active cancer, so 1 point will be added. If the patient will have a hemolysis, platelet count less than 30,000, and the patient, if have a no history of solid organ or hematopoietic stem cell transplant history, so you'll get one marks per 1 point. And your mean corpuscle volume should be less than 90, INR less than 1.5, and creatinine less than 2. So these are the few cutoffs for determining your plasmic score. Now, up again a question: 85-year-old male, critically ill patient. He is having a gram-negative sepsis. He is on vasopressors and broader spectrum antibiotic. Every alternate day, he is receiving a hemodialysis. And we have noted that spontaneous bleeding is coming from the central line as well as hemodialysis catheter. Lab finding shows a anemia like hemoglobin of 7, and WBC is very high, 45,000. Platelet is very low, 23,000 only. And prothrombin time is very, very high, that 30 seconds. And prothrombin PTT is again high. INR is deranged like 3. Fibrinogen is very, very less, only 50. So what is the appropriate next management? I think again it's a very straight question for you all. Good. I think you all have marked right. So you will transfuse your CPP. Okay. So transfuse the CPP. Now it looks why. So the presentation, classic presentation is DIC, and this treatment as DIC underlying is you have to replace this fibrinogen, because fibrinogen is only 50, by transfusing cryoprecipitate to achieve a level of more than 100 milligram per dl. So choice D is correct. And human clinical trials has a mixed result with the use of heparin to treat DIC, and hence it is not recommended according to the current guidelines. So for heparin is not recommended, and the performing additional dialysis at this point of time would have a little effect on its bleeding diathesis. So here bleeding diathesis is there. So if we do a dialysis, again the problem will be more aggravated. And last here, because patient will have a fibrinogen very low level. That's why the both prolongation in PT and APTT is there. That's why transfusing FF will not help. Is not the best correct option. That's why you look for the statements. Here the fibrinogen is much consumed. So we want to supplement this fibrinogen, and we want to correct at least 100 milligram per dl. And when that will be achieved, your patient will stop bleeding, or bleeding diathesis will be not there. Now, this is again a very interesting question, that all of the following are acquired causes of normal PT and APTT except. Okay. So I have enumerated all causes of all acquired causes. Here, one cause is the congenital cause, in which PT as well as APTT both are normal. I think this is the last, and this again after that one more question will be there. Any of you who mark it, I think answer is already written. So just see this, revise this table. I think this is the important table here. This all the causes are acquired one, and this is the congenital causes. So the congenital causes or acquired causes are in which both APTT and PT will be normal if the patient will receive a low molecular heparin therapy, fondaparinux therapy, or antiplatelet therapy. That's why your therapeutic monitoring is not required, or you doesn't require to monitor your prothrombin level or APTT level if your patient is on LMWH or fondaparinux or antiplatelet. If the patient will have a acquired von Willebrand disease, or if a patient will have a congenital von Willebrand disease. So this is von Willebrand disease, the patient will have a normal. The scurvy is again a cause for acquired cause, and acquired thrombocytopenia. I think thrombocytopenia everyone will mark. The scurvy may be one of the choice where PT and APTT will be normal. Okay. So this is the correct answer. Now, this is the last question of this session. All of the following statement about factor 5 are true except. So you have to mark it false statement. So if you see the closely option, it is most commonly associated with mucocutaneous bleeding and rarely ICH. So ICH is very rare presentation of factor 5 deficiency, and these are moderate and severe deficiency. There are moderate and severe deficiency states. No, they are a mild, moderate, and severe deficiency states. So again, statement is not right. And in severe deficiency patient, the patient will have an umbilical stump. Yes, of the all those patients who are having a severe factor 5 deficiency, they present with umbilical stump bleeding or mucocutaneous bleeding. They have to be treated with FFP, and always try to achieve a goal level of replacement of 20 to 30% by using FFP. And the last point is, so again, this statement is right. And alpha granule is in platelets always contains factor 5. Okay, so platelet transfusion have been used in factor 5 deficiency, but you have to check whether this patient is have developed any neutralizing inhibitors to factor 5. That's why this option is not right. I've already explained all those questions. So this is a first statement. This is second statement. So there are three forms: mild, moderate, and severe deficiency. And factor 5 deficiency is treated by FFP. Your goal should be 20 to 30%. And alpha granules in the platelet always contains factor 5. Okay. That's why platelet transfusion can be utilized in cases of factor 5 deficiencies. So this is all about from my sides. And so if you have any query, you can mail me directly. You can write my mail, and then we'll have a discussion there also if you have any doubts or any question. So this is all about from my side, and I think after a 5 minutes break, we can go with the second topic, that is your here that is the next part, your obstetric malignancies, where I think I have kept a few important points, like all important parameters like amniotic fluid embolism, preeclampsia, then your DIC, then your Budd-Chiari syndrome, then your press. We have discussed one question related to press, like that. So I think again that that will be a very nice discussion. And I am very thankful to all participants who have at least attempted all these questions. Do write if you want any, if you have any suggestions regarding that today's session.